Good morning. Sorry for being late by 10 minutes. Today we have two short cases for discussion. One is on congenital hernia and one is on umbilical discharge. Dr. Diptyavan Nandi is a first year junior resident at MR Mohan Hospital, present the case. And with me today will be Professor Kolani Basu, Professor and Head of Pediatric Surgery at NRS Medical College, will join. She is joining. Diptyavan, you can present the first case.
Good morning, everybody, my respected teachers, seniors, and dear colleagues. The first short case is about congenital hernia. This is a 11-month-old male child presented in our OPD with a swelling in left inguinal-scrotal region since birth, and since then the swelling is gradually increasing in size. History of present illness. The respondent is the child's mother. At 11-month male child presents with a swelling in left inguinal-scrotal region since birth, and since then the swelling is gradually increasing in size. The swelling increases when the child sits, crawls, and strains, but it disappears when the child lies down. History of past illness. He was a full-term baby and of normal vaginal delivery. Birth weight is about 2.9 kg. Neonatal period was uneventful, and vaccination of the child was up to date. Personal history: bowel bladder regular, sleep normal. Family history: nothing significant. General examination: patient is conscious, alert, cooperative. Pulse, BP within normal limits, no external deformity noted. Abdominal examination: there is a left-sided inguinal-scrotal swelling showing expansile impulse on calf. The swelling is reducible and there is a gargling sound during reduction. The summary of the total case: 11-month-old male child present with a swelling in left inguinal-scrotal region since birth, and since then the swelling is gradually increasing in size. The swelling increases when the child sits, crawls, and strains, but it disappears when the child lies down. On examination, there is a left-sided inguinal-scrotal swelling showing expansile impulse on calf. The swelling is reducible and there is a gargling sound during reduction. So this is a case of left-sided congenital hernia in a 11-month-old male child, and the content is intestine.
Okay, the presentation is okay, but you have mentioned something as history of past illness. There is no history, that is birth history. What I mentioned is full-term child, vaginal delivery there, but this is not history of past illness. This is birth history. And in examination, what you have done is it's an examination of the inguinal-scrotal region. And you must mention whether the patient has got associated normal descended testes. Okay, often this hernia may be associated with the undescended testes. So you should mention the genitalia also in this patient. Okay, you said it's a case of congenital hernia. Okay, why? What are the points in favor of diagnosis that it's a congenital
hernia? So because the age of the child and the swelling was present since birth, and as the child is increasing in age, the swelling is also gradually increasing.
Why it is hernia and why it is a congenital hernia? It's 11-month-old child, swelling is present since birth, so it has to be congenital. And it's hernia, why? What are the points even of hernia in this patient? Is there in the history? Is there in the examination?
Yes, sir. Inguinal-scrotal swelling, expansion impulse, swelling is reducible.
You see, when you have such question, you should start with the history. In the history, mother complained that there is a swelling in the inguinal-scrotal region, and that swelling increases on strenuous activities and getting reduced on lying down. So that is the point in favor of the hernia in history. On examination, you find a swelling in the inguinal-scrotal region, which is showing some increase in size. 11-month-old child may not obey command that he is coughing, so he may strain, and on straining, the swelling is increasing in size. Okay, so the other points in our hernia. There is another condition in this age group which is called as congenital hydrocele. What is the difference between a congenital hydrocele and congenital hernia? What is the difference between a congenital hernia and congenital hydrocele? What is the defect in congenital hydrocele? Why this congenital hernia occurs?
So,
Why the congenital hernia occurs?
so processes vagin.
Yes. What is that? What is processus vaginalis? Which drags this processus vaginalis down? Which drags the processus vaginalis down? This happens during descent of testes. If you take the processus vaginalis, this is the prolongation of peritoneum from the groin to the scrotum. So if you take this processus vaginalis, what is the fate of the processus vaginalis in a normal situation? What happened to the distal part? What happened to the intervening part? The other length of the processus vaginalis. That's why I'm asking why congenital hernia occurs. What is the defect in congenital hernia?
Wherein the descent part of the
And that's what I'm saying. If you see the processus vaginalis, it has got an opening in the region of deep ring. And this peritoneal prolongation goes to the bottom of the scrotum. So that is the whole length of the processus vaginalis.
when the
Now
migration
tell me what happened to this processus vaginalis. What is the normal fate of this processus vaginalis?
so,
What happened to the most distal part? You have heard of tunica vaginalis? What happened? How from this is derived?
it is derived from process.
So in normal situations, the distal part of the processus vaginalis persists, and this forms the visceral layer, and the parietal layer, the tunica vaginalis. From the upper pole of testis up to the deep ring, this length of processus vaginalis, what happens? Disappears. In normal circumstances, only the distal part of processus vaginalis persists. The remaining part of processus vaginalis disappears. What may be the abnormalities?
So when the portion doesn't disappear, then it
Which portion? Which portion? You see, what happens to the testis part is at the upper pole of testis, from that point to deep ring, this processus disappears. And from the upper pole, this prolongation forms the tunica vaginalis. So it can persist to the whole length. So what will happen to this hernia? How far this hernia will go? If the whole processus remain patent, how far this hernia will go?
the scrotum,
It will go to the
bottom
bottom of the scrotum. So congenital hernia occurs when the whole length of the processus vaginalis is persisting from deep ring up to the bottom of the scrotum, because this processus vaginalis has not getting occluded from the upper pole of testis to the deep ring. Whole length is persistent. That is one. What other abnormalities may happen apart from having the whole length being open?
So tunica vaginalis formation is defective.
Tunica vaginalis is a normal situation. When it gets cut off at the upper pole of testis, the lower part persists as tunica vaginalis, and the upper, the remaining part disappears. I am saying one abnormality is the whole length of processus vaginalis is persisting. What may be the other abnormalities? These are all clinical situations. What else may happen? Have you heard of the term encysted hydrocele of the cord? What is that? When does the encysted hydrocele of the cord happens?
When Portion of processus vaginalis.
Yes, which portion?
Sir,
Processus vaginalis has got a portion in the umbilical canal, has got a portion in the around the testis and the intervening part. Which part?
So intervening.
Yes. So if the intervening part of the processus vaginalis is persistent, there will be collection of fluid inside this, and that forms
Insisted.
hydrocephalus. Another situation may be when it is patent from the deep ring up to the upper pole of testis. What is that type of hernia called as? What is that type of hernia called as? This is funicular type of hernia. Funicular type of hernia. Okay. So these are the different situations because of abnormalities of processus vaginalis. Now I ask you another question. How do you differentiate between a congenital hernia and congenital hydrocele? What happens in congenital hydrocele with respect to the processus vaginalis? Is there a difference between congenital hernia and congenital hydrocele with respect to the processus vaginalis? No. In congenital hydrocele also, the whole length of processus vaginalis persists. The difference between congenital hernia and congenital hydrocele is, in congenital hydrocele, there is fluid in this sac. And he said here that there is gargling sound in reduction. That means this patient in the processus persistent part, there is cut. So it can be momentum also. So if this processus persistent sac contains some viscous, it is a hernia. If it contains some fluid, it is hydrocele. And that hydrocele is called as congenital hydrocele. Good morning, madam.
Good morning, madam.
Please unmute, madam.
Am I audible now?
Yes, you're audible. Diptaman has presented a case. There is a summary. And I just asked him what are the different abnormalities of processus vaginalis. So he partially answered. I answered the remaining part. So the summary, you can just summarize again to madam.
Madam, this is a 11-month-old male child presented in our OPD with a swelling in the left inguinal region since birth, and since then the swelling is gradually increasing in size. The swelling increases when the child sits, crawls, and strains, but it disappears when the child lies down. On examination, there is a left-sided inguinoscrotal swelling showing expansion impulse on cup. The swelling is reducible and there is a gargling sound during reduction. So this is probably a case of left-sided congenital hernia in an 11-month-old male child, and the content is intestine.
You mentioned nothing about the other scrotal contents, whether the testes are present on both sides in the scrotum. What about the external urethral meatus, whether it's normal or not?
So you should examine the genitalia also in this patient. See, what is that?
Part of the examination. And if you are presenting as a short case, you will have to mention that. And regarding the history, you will have to ask the mother whether the patient's at least urinary stream is normal or not. And when the swelling appeared, was it present since birth or it
that is
appeared?
given it was since birth. It was since birth. But you have to mention that I told you. You have to examine the genitalia because this hernia may be actually undescended testes also. Patient having undescended testes may have actually inguinal hernia. So in that case, you have to also confirm whether the normal descended testis is present or not.
Okay.
So he justified that.
How will you? Pardon, sir, repeat your question.
He answered that. I asked about the different abnormalities of processus vaginalis. The distal part is forming tunica vaginalis. The intervening part percent called hydrocele. So he has answered that part. We have discussed the fate of processus vaginalis.
how will you manage this child?
How will you manage your diagnosis? Have you any differential diagnosis?
Yes.
So differential diagnosis is congenital.
You see, hernia is a clinical diagnosis in the history of swelling since birth, increase in coughing. So there is unlikely to be a differential diagnosis. So this is easily a straightforward case with a classical history and classical finding. Okay, madam has asked, how will you manage this patient?
Sir, madam, in doing some baseline investigations, this is the treatment of choice in this case is herniotomy.
Suppose this baby has presented to you at the age of 25 days. So when will you operate? And if the baby is now, as you said, it's 11 months old, when will you operate? A baby whose presence within the neonatal period, that is within 30 days of life, with an uncomplicated inguinal hernia which reduces on its own. When will you time your operation? And like this less than 1 year old child, when will you time?
When? Will you wait or will you operate early?
In the neonatal, early neonatal period, we can wait.
No.
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 Chances of obstruction, strangulation, irreducibility is much more higher in neonatal period. So
Yes.
if a child presents to you in the less than 30 days old, should operate as soon as possible. That is, investigate and operate on the next day. And that's true for a preterm child also, preterm baby. But so after beyond 1 year, you can plan as an elective surgery. So will you admit the child or will you perform it as on a daycare basis?
Daycare basis.
Yes, most of the time we operate. For neonates, it should always be hospital admission. But beyond neonatal age, you can operate on daycare basis.
Daycare means it's not under local anesthesia. Try to understand. In a neonatal and these.
Yeah, I mean, it is under general anesthesia, but to reduce the hospital stay and separation anxiety from the family, we call in the child on the same day with for 4 hours of fasting is enough. If clear fluid allowed, suppose clear fluid was allowed at 6 a.m. by 10 a.m. you can operate on the child and you observe after operation for 4 hours. Once the child is awake and passes urine, you can discharge the child provided they are not coming from a very remote place. They have got easy access to healthcare facility and they can report to the hospital in case there is an emergency.
Oh, okay.
Will you do some investigation?
Yes, what are the investigations will you perform?
With this presentation, do you need an investigation to confirm your diagnosis of hernia?
No specific investigation is required.
Yes. Yes. But if you have accelerated undescended testis,
Then some investigations like ultrasonography should be done.
Sir, I beg to differ because ultrasonography these days is not really considered as an investigation. Most of the residence facilities where they work is available in the ward and they are supposed to be having some expertise in performing USG themselves. Since the association of a patent processes vaginalis is quite high, especially if the hernia is in a female on the left side, the right side also having patent processes vaginalis, which is not clinically a hernia right now. And so an ultrasonography, I feel, should be done both the.
okay. And then particularly if you have undescended testis, you can also localize the testis, whether it is in inguinal canal or not. But interabdominal testis, you cannot make out in ultrasonography. But okay, take it that is a hernia only.
And suppose this was an hydroceal, like there's a term called fluid hernia.
Yes.
It's only the diameter of the processus vaginalis which differentiates between a congenital hernia and hydrocele. Since the congenital hydrocele does not require immediate treatment and can be observed till the age of 5 years unless it's very large and causing discomfort to the patient. So an ultrasonography, I think, is useful to detect whether there's any content like momentum or intestine or it's simple fluid hernia. In all the cases, at least we recommend ultrasonography of the bilateral immunoscrotal region be done. There is another implication, I mean, medico-legal importance for this. That is, if the testes both are descended before surgery and after surgery, if by chance the hernia ascended, the testis ascends, ascended testis is I mean, existent entity, especially after immunoscrotal surgery for hernia. So you can document, yes, your both testes were present in the scrotum beforehand and after operation also they were present, especially if the vessels and the wares are not handled properly during surgery. In 5 to 10% of the cases, when not done under proper circumstances, an expert person who is acquainted with the anatomy of such a tender will then the atrophy of the vessel. Any other investigation apart from ultrasound? Whatever you need for general anesthesia. General anesthesia is general anesthesia, however short is the duration. So
Yes,
just
madam.
enumerate what investigation you will do.
What basic investigation you need to do?
For anesthetic purposes, the investigations like CBC, LFT, renal function test, chest X-ray,
You can routine LFT for a just a hernia patient. You don't do routine LFT.
chest X-ray.
You do a hemogram, yes, hemoglobin, TLC, DLC, a chest X-ray. You can do a routine urine examination. Okay, a routine LFT is not advisable for all patients. Madam, you do LFT for all patients? No.
No, but coagulation parameters,
PTINR.
and not BT bleeding time, clotting time will not give you the same proper picture. So it's better to perform a PTI. And I don't feel echocardiogram is also necessary. The anesthetist is emphasize have echo for all patients. I think that's over. Unless the patient has got a history of cyanotic heart disease and on
Yes.
auscultation, you find any abnormality,
Hmm.
simply ECG is enough. Echocardiogram.
Okay. What treatment you will offer? What is the optimal surgical treatment for patient of a congenital hernia?
So hernia problem.
Madam said there is a chance of hernia on the other side. So what is the strategy?
So observation and
Observation, and you must counsel the parent that even after performing surgery on this side, 3 to 6 months later, the hernia will appear on the other side. Most of the time, the parents will come and blame you these days that you have operated on this side, the other side has come up now. And when if they are not made aware beforehand, even if they are made aware, they can tell you, why don't you tackle both sides? But you should refrain from it and you should ask them that will tackle the other side as and when it is necessary. There is no question of performing a prophylactic surgery on the other side. Suppose this was a female patient with a congenital hernia on one side. How will you manage? You have got all facilities available. Female patient with congenital inguinal hernia.
Now you have the facility for doing a laparoscopic herniatomy also.
And the advantage of that is you can occlude the ring of the opposite ring at the same seat. I feel for female children, it is advisable to perform laparoscopic craniotomy and occlusion of the ring on the
So, madam, that will be a prophylactic approach.
Yes, that is because you are, that is a minimally invasive surgery. You are performing laparoscopy. You are going into the peritoneal cavity. So why do you leave the other side to chance? And especially for females, the only content of the inguinal canal is the
Round
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 ligament.
ligament of it.
There is no harm in performing prophylactic approach. That way, you avoid the subjecting the child for another operation or general anesthesia later on. But in a male child, there is a different entity. As I said, that all the structures are very delicate, and it's not certain that the other side may remain as a patent processes for a till the age of 6 years. Clinical hernia may or may not appear. So why subject the other cord and the testis to an operative trauma?
Now, even in adults, some people are vouching that they should do a routine opposite-sided hernioplasty, put a mesh. But there are a lot of controversy in that. Even adult
Yes.
people are vouching that you do a prophylactic mesh from the other side. Some people are practicing this, but this is not standard of care. Okay, ma'am,
What
can
is
you
the
go to the
operation?
next case?
I just have one more question.
Yeah.
What is the treatment for congenital hydrocele? What do you do? Because I have seen general surgery senior residents soon after being posted in my department committing some mistakes regarding this issue. So what is the treatment of congenital hydrocele?
So initially, no intervention should be given, and it is better to wait and watch.
Till how long?
So at least 5 years. I mean, 5 years of age, the child.
And it does not disappear, it's a very huge one. What do you do then?
What is the
What
treatment for
operation
congenital
do you
hydrocele
perform?
when you decide to operate? What is the operation? Is it different from a hernia operation? What is the operation? The pathology is patent procedure behind this.
So, obliteration of the.
What obliteration? What is the name of the surgery?
High
Hernia
ligation. No, it's not hernia. There's no hernia. It's only the persistent processes vaginalis. So
Yes.
you have to do high ligation of the persistent processes and
High
laying
ligation.
open of the processes. There is no need of eversion of the sac that
Yeah.
you do in an adult patient.
Normal,
You just
hard
lay
ligation.
open the sac, evacuate the fluid. If it's a very large one, you can put in a drain, and after 48 hours you remove the drain, but there is no performed diversion. And suppose this hernia was associated with an undescended testis in a 1-month-old child, what operation will you do? Unobstructed.
Unobstructed
Reduce
hernia with undescended testis.
with undescended testis, 1-month-old child. Every point is
Undescended.
Undescended testis needs say ascended orchidopexy. So if it is 1 month child, so will you do in 1 month or you like to wait for some time?
Sir, wait for some time in case of
No.
undescended.
As I said, in 1-month-old child also, the hernia can obstruct. So you tackle both issues at the same age. You do not leave the undescended testis part orchidopexy for a later stage, or you do not leave the hernia also. Tackle it at the same time, at the same stage. Loss of testis is very high if the hernia gets irreducible or obstructed. And in an 11-month-old child who has got hernia along with undescended testis, to do the orchidopexy and herniotomy at the same stage. Because if you separate these two things, later on doing orchidopexy will be impossible due to adhesions. So you tackle it at the same time. Okay, sir, proceed for the next.
Yeah, actually earlier there was a strategy of waiting for about 18 months for orchidopexy, but people are now saying that you can do orchidopexy as early as possible.
Sir, I think we should enumerate the post-operative complaints.
Yes. what complication can occur following a simple herniotomy?
So normal post-operative complications like bleeding, infection.
There's
This
nothing
will
called normal complication. You can say it's usual complications or otherwise, I mean, adject. There's no need of putting any adjective. Say early complication, late complication. It is better to classify that way. So the early
Early.
complications are
Bleeding leading to hematoma, then
hematoma, infection. These are early complications.
sir, you didn't listen properly. When I said that you perform the daycare surgery and when do you allow the patient to go home? After the child passes urine. So the first complication that can happen is detention. You do not allow the child to go home after hernia surgery till baby has passed urine. The first complication I think should be retention of urine. Then, as sir said, there can be hematoma, wound infection, edema, and if there is a large sac, especially, the edema may persist for some time. So, you'll have to reassure the parents that this edema will go away, but it may take about a week's time. And what are the late complications of herniatomy? I mentioned all those also in previous part of discussion.
if you are not very meticulous while doing surgery, this patient may have some delayed complication.
So there can be recurrence.
Apart from recurrence,
recurrence is of hernia and
there can be injury to
injury to vas. And also, if you injure the vessel, what can happen?
There will be necrosis.
There can be
testicular or vessel block can produce fertility problems later on. And as I mentioned earlier, that while performing surgery, sometimes to discharge the testis from the scrotum, and before closing, you must ensure that you have put the testis back into the scrotum. Otherwise, the testis will be held up with scar tissue higher up near the superficial inguinal ring, and that will be an acquired ascended testis. That part is very important, that you reposition the testis back into the scrotum after surgery to prevent this complication.
And you should place in proper alignment. That means sinus of testis should be looking laterally. Otherwise, there will be iatrogenic torsion also. Okay, madam, we can pass to the next case.
Yes, Prashant.
Yeah. Umbilical discharge. Next.
This is in this case, a 1-year-old child presented with a male child also. This one is presented in our OPD with mucus and occasional purulent discharge. History of present illness. The respondent is mother. A 1-year-old male child presented with mucus and occasional feculent discharge through the umbilicus since birth, which also increases on crying. Mother also says that there is a reddish mass protruding from the umbilicus for last 6 months. History of past illness or birth history. This should be birth history. This is a full-term baby of normal vaginal delivery. Birth weight is about 2.8 kg. Neonatal period was uneventful and the baby was fully vaccinated up to date. Personal history, bowel, bladder regular, sleep normal, family history, nothing significant. In general examination, patient was
history is incomplete here. Whether the baby born in hospital or at home and what material was used for clamping the umbilical cord. That is important. Was it ligated in a sterile manner, proper aseptic and antiseptic precaution, and when did the umbilical cord separate? If you ask that history, usually it separates by 5 to 7 days maximum. And was the purulent discharge that you mentioned, because till 7 days the baby has got the drying up umbilical cord attached to the navel. So how can the purulent or mucoid discharge come out? Where from was it coming out? You have to ask the mother properly about that. It can come out. There might be even prolapse of gut loops if there is a patent vitalo-intestinal duct. The whole I mean, a considerable length of ileum can herniate through that, and like two elephant trunks from the umbilicus, it can prolapse even in a newborn. So your mother, the baby's mother said that there is a reddish mass in the umbilicus, and there is purulent and mucoid discharge from the umbilicus. Did you ask whether there is any fecal discharge or uriniferous smell? That is also important.
Yeah, he said feculent also. But in the birth history, madam has mentioned that it's mentioned is institutional delivery and patient has umbilicus is clamped with a proper
tie.
cord clamp and it's shutted off by about 7 days. But following that, patient mother noticed that patient has got some discharge. So this history should be covered.
And if there is uriniferous discharge from the umbilicus, whether the how was the baby's urinary stream? Did the baby pass urine within first 48 hours, and the urinary stream in a male baby is it projectile? There is no strain in urine, because if there is a bladder outflow obstruction, then there will be uriniferous discharge through patent urachus, and the baby will have pass urine, non-projectile or stream of drop by drop urine. Okay, now you proceed with the history, rest of your general and exam.
Abdominal on examination, there is a patient is conscious, alert, cooperative, vitals within normal limits, skin condition is normal.
Because in your MS exam, you don't measure BP of a 10-month-old child or 1-year-old child. It's not necessary also. Okay, we say at least pulse.
If
In
the
abdomen,
baby is having a persistent discharge, the skin around the umbilicus is normal, that is not really tenable. There will be at least some dermatitis, because all the secretions that is coming out, it is ileal secretion, it is very irritant to the rest of the skin. So there will be some skin changes. So while presenting, you have to do if it is not at all there, because the examiner will be able to see your patient. So you don't say anything that is not there, but otherwise it's not really tenable, that the skin will be absolutely normal. Okay, rest of the exam.
on abdominal examination, there is a slight feculent discharge through the umbilicus. Reddish mucous membrane is seen prolapsing through the umbilicus.
First is you mention the position of the umbilicus, whether, because that is the main focus of your examination part. It might be associated with some hernia, or there might be some indurated area around it. On pressing, more of discharges come out, or whether you can palpate the lift of the umbilicus from the rest of the parietes, and whether you can palpate any other swelling from the umbilicus to the hypogastric region, because be it a patent processus vaginalis or be it a patent urachus, there might be some swelling in between the tracts due to entrapment of the secretion. So you'll have to elaborate to your local examination a bit more. And
Then you
you
do a
should
comprehensive
also,
abdominal examination. You have just mentioned about the umbilical part. But you may make a heading of abdominal examination. So it should be abdominal examination as a whole.
because he's proceeded to the next slide with his summary, and there also it's written, and on examination there is a slight equivalent discharge to the umbilicus, and reddish mucous membrane is seen prolapsing
No,
to
no.
the
It should be a comprehensive abdominal examination because these patients have actually intestinal obstruction. Patient with a personal VID may have ulcerated Meckel's. So patient may have occasional pain abdomen. So it should be a comprehensive abdominal examination.
any history of hematochezia might be there, and there are many syndromes associated with umbilical hernia also. So umbilical hernia, whether it's and patent PID may also be associated with umbilical hernia. So you'll have to elaborate on the umbilicus, the position of the umbilicus, and as I said, whether there is any other associated swelling just beneath the umbilicus. You try to lift up the umbilicus and try to feel underneath. And whether on pressing the tract more of a discharge comes out or not, there might be some collection under. And you make the child cry and see if there is any umbilical hernia. And you must palpate the rest of the abdomen for any hepatosplenomegaly, any other mass, any visible peristalsis. Okay. Your diagnosis is a case of umbilical discharge associated with fecal fistula due to persistent PID. Okay. How will you investigate the case? How will you investigate or confirm your diagnosis?
Yeah, why you hesitate saying ultrasonography? Ultrasound is now an extension of clinical examination. Ultrasound is must.
USG, madam.
What type? You have to mention high resolution ultrasonography. They nicely delineate the tract, whether there is any, as I said, any swelling in between, like the patent urachus or in the patent PID. There is a swelling in between. The communication with the bladder or the intestinal tract, they can nicely delineate. So ultrasonography is a must. And what else?
CT scan.
Why?
Why? You can see obvious purulent, obvious feculent
And
discharge.
discharge. Why do you need a CT scan?
Why you need? You know there is a communication with the intestinal tract. Had it been urine, you would have needed some other investigation. Instead of feculent discharge, if the baby is discharging urine from the umbilicus, uriniferous smell in that dressing that they are applying, what other investigations will you perform? The ultrasonography should be used to check the both the kidneys, whether there is hydronephrosis, hydroureter, and the bladder is palpable or not. Because if there is post-urethral valve and bladder outflow obstruction is there, the bladder will be palpable. And so you'll have to look for that. But how is the bladder? And if there is obvious feculent discharge, an ultrasonography is sufficient. You don't need to do a CT scan or a dye study. And if the swelling is, if that umbilical discharge is urine, then apart from ultrasonography, what other investigation will you perform?
Because
To
these patients have associated lower
exclude
intestinal
bladder
obstruction.
outflow.
Urethrogram. IVP.
IVP. Why IVP?
No.
That is not called urethrogram, that is called micturating cystourethrogram, MCU, or voiding cystourethrogram. But the prerequisite is to do that is baby must be having a sterile urine. You do not perform a VCUG or MCUG without performing an urine routine and culture sensitivity examination first. And usually VCUG is sufficient enough to exclude your bladder outflow obstruction. You do not need IVU for that. IVU cannot exclude bladder outflow obstruction. It will only show a large amount of post-voiding. So MCU is the investigation. So now let us come to this patient who's got feculent discharge with umbilicus. So how will you manage this case? Any role of performing sinogram? You can't
Yes.
do that. Cannulate with a large caliber gelco Teflon sheet, put in some dye. If the dye reaches your intestinal
What do you
tract,
expect? If you put dye through this fistula tract, where the dye is likely to go? Which part of the gut? Right? Which part of ileum?
Vitilo-intestinal duct joins the intestine at the ileum. Which part? As I said, the rule of two.
Rule of two.
Meckel's diaculum.
2 feet from ileocecal junction. And the length of the Meckel's diaculum is 2 inches. Okay, so based on this diagnosis, what should be your
We have already discussed the operative preparation,
Yeah.
operative management. Will you perform this as a daycare surgery, this operation?
No, this cannot be.
there should not be a daycare
Yes,
surgery because you have
if you
to.
call him on the same day, you inform the patient that after operation, this patient will need admission because this communication with the bowel, you cannot allow the child to go away on the same day. And is bowel preparation mandatory?
Do you need a bowel preparation?
No. Bowel preparation not so mandatory.
Bowel preparation is not needed, but you said that your baby is 1 year old. 1 year old baby takes solid diet and stool in ileum is quite firm consistency. So even if you don't require things like PG or antibiotics, at least you ask the mother for 24 hours, withhold the baby from any solid food, just liquid diet, and 6 hours prior to surgery, only clear fluid in the form of water, ORS, and glucose water. So that the contents that is there is liquid and it can be removed if there is any during surgery with proper suction. You don't want your peritoneal cavity contaminated with well-formed ileals, isn't it so? So what operation will you perform? Where will you place your
It's not a fistula. It's not a fistula. It is a persistent VID extending from umbilicus up to the terminal ileum. So what is the operation? It's not fistulatum. What do you have to do? Now, at least now think of the VID. What is VID?
Excision of the
Elaborate the what alphabet VID.
vital intestinal duct.
What is that?
It is a derivative of the.
You need to learn a little bit of embryology here. When the fetus is in a trilaminar state, it's a flat disc. Then it folds upon itself and incorporates the yolk sac within its abdominal cavity, and that forms the growing intestinal tract. So it's communicating from the
They say diverticulum from the midgut,
midgut,
which goes to the through the umbilicus.
By intestinal tract to the umbilicus. So you have to operation. What will you write on your OT note? Your sister should know, OT sister, what operation you are going to perform. That's how they are going to prepare the table. So it should be exploration of the umbilicus, excision of the patent VID, if any, and reconstruction of the umbilicus, which is very important. Cosmetically, umbilicus is very important to everybody. So that is the operation that you should write on your note. And suppose it has got a wide communication with the ileum, the base of the Meckel's diverticulum or
As you trace, there is a wide base of this opening into the ileum. Will you just do a flush cut or do something else?
No, that wide area should be anastomosed or.
Why?
These days we do not perform wedge excision because chances of fecal fistula formation after wedge excision is very high. So you perform an RA. There's no wedge excision can be done only if the base is very small, say about 1 centimeter or less than 1 centimeter. Then and then only you can perform wedge excision. And another issue why we do not perform wedge excision, because there may be harboring something there. What is? Why do
you need to remove a part of small gut? What is there? For what reason you need to remove a part of the ileum?
Atrophy.
Ectopic?
No. ectopic, gastric,
Pancreatic tissue.
and the ulceration
Ectopic,
forms at
pancreatic, and
the
gastric
opposite
tissue may be
end.
there.
And the ulceration forms at the opposite end, that is on the mesenteric side. That's why you should always do resection and anastomosis and send the specimen for biopsy examination. That is also essential. Do you put in a drain? At least I do. I'm not very timid because I want to detect my anastomotic leakage early, so I put in a drain, which can be removed from 48 hours. If the child passes stool, you can start feeding clear fluid, water and waters. From 3 days onwards, you can start breastfeeding. Anyway, how do you reconstruct the umbilicus? Because you have excised all unhealthy tissue over there. That red fleshy mass that was coming out from the umbilicus right up to the vital intestinal duct, you have excised. And you must inspect the rest of the bowel. If required, you extend your incision. You didn't tell me also what will be the incision. Usually it is subumbilical incision extending to right transverse at the umbilical level if you want to do a proper RA. Just by subumbilical incision, it may not be always easy. And how do you reconstruct the umbilicus?
Because this, you said there is a fleshy mass protruding in the umbilicus.
Operation
that is the
करना
most distal part of the VID. So you have to excise that protruding mass also. So madam is now asking, if you excise this, now umbilicus is now free from the underlying linear alba. What do you do?
You excise the whole of unhealthy tissue, whatever is there. So now there is a big circular gap in the skin. So you
Yes.
put in a purstring suture on not at the cuticular level, the subcuticular stitches, and that purstring is to be fixed at the linea alba after closure of the abdomen. And or sometimes what we do, we take out the drain from the same side. One thin narrow stream of a corrugated PVC drain, you take it out from that. It keeps the umbilicus tethered to that situation. But if you ask me, I prefer to put in the drain from other side and do an umbilicoplasty.
It's umbilicoplasty.
Umbilicoplasty.
So you have a gap in the umbilicus. You close this gap and fix this umbilicus center to the linear alba.
Linear alba.
That creates a normal umbilicus with a
Umbilicoplasty.
proper depression.
What will be the post-operative complication?
Post-op complication.
Early and delayed.
Early complication, madam, difficulty in bowel movement.
Of early complication, again you are doing a surgery, dissecting, doing a resection anastomosis, again bleeding should be a problem.
Bleeding,
Bleeding,
persistent
wound infection.
Wound infection,
That's why
then
it is
anastomotic
mandatory
leak.
to do a pressure dressing. That's why you should do a pressure dressing after an umbilicoplasty. Then the delayed will be, failed anastomosis and fecal leakage, recurrence of fecal leakage, intestinal obstruction. Okay. Any specific wound care that you will advise? It's preferable not to use ointments. What happens? Mothers usually do not clean the area properly and go on applying antibiotic ointments over and over.
In pediatric patient, you try to give a subcuticular stitches so that again removing a suture is another difficult task.
Another headache. Better to use some topical antibiotic drops and keep the wound dry. Suppose this was an urinary discharge, what will you do? And there is posterior urethral valve. I'll just ask.
Wait for me.
Enumerate in one line. I'm not going to in detail of posterior urethral valve. Just in one line, patent urachus, what will you?
Patent urachus often presents in adult age. Why? Patent urachus often does not present in the early age group. Even if there is a patent urachus, if you have no distal urinary obstruction, there is no discharge of urine through the patent urachus. So in younger patient, you have the presentation with uriniferous discharge if there is associated lower urinary obstruction in the form of posturethral valve. This can often present in adult patient when patient has got a bladder outlet obstruction.
In the form of prostatomegaly.
Or stricture urethra.
Or stricture urethra. So you have to address the issue of lower urinary tract obstruction, and at the same time, while you excise the urachus, you excise a small part of the dome of bladder along it, and those give bladder in 2 layers. Often, not often, I mean, while performing this, you will have to keep a periurethral catheter drainage at least for 7 days. Do not put in an SPC once again, because that problem is at first. Put in a properly fitting periurethral catheter and repair that part of the bladder where it was continued as the patent urachus. The obliteration of the tract and ligating and dividing of the urachus will not suffice.
Okay, madam, I think we have gone beyond 9.
Yes, I have to.
Thank you, madam. Thank you.
Thank you.
We have
Thanks
good-
a lot.
Thank you,
Thank you,
madam.
madam.
Thank you.